mission director for telecommunication. I think if you see that the rural areas are telephones today, I think DT Narayan is one of the responsible persons for that. And tremendously efficient. I think I can just give you an anecdotal thing that Vinod Goswami, the patient of mine, met me one day and he praised a lot about DT Narayan. I asked him what happened. Apparently that is about nearly 20 years ago when DT Narayan was the principal general manager of telephones here. And Mr. Goswami had applied for telephone. At that time, to get a telephone, it would be 2 or 3 years. And sometimes we had a person in our area also. But after 3 years of finding difficulty, he went to the office of Mr. DT Narayan. He was so gracious, he stood up and said, "Sir, why did you come?" So the Goswami explained apparently that I have applied 3 years ago, it's not come. So he said, "Please just go home. By the time you reach your telephone, will be installed." And it was installed in time. So that was the efficiency of Mr. DT Narayan. We're proud of him, and it's an emotional privilege to deliver this lecture in his name. So, and when you see all the degrees, you would probably wonder, where is the degree for tissue engineering? I don't have any. But it's an emotional transition from a clinician to cell biology and into biotechnology. So what is this tissue engineering? So what I'm going to do is that describe about what this tissue engineering is about and what is the fantasizing ideas we have of tissue engineering, or what experimental designs that have happened and what actually is reality. So I will stick to all these 4 items about tissue engineering. Engineering of a tissue is what basically tissue engineering is. So we engineer the tissues to the desired level of optimization, the amount of tissue thickness, the activity, functionality, and chemistry or secretion activity, whatever you want to design. Designing the tissues and organs or organ regeneration is a tissue engineering. It's a combination of multiple specialties. I think Dr. Rao said physics. Physics is one of the basis of tissue engineering because all of our activity, quality control parameters, they all are based on molecular physics. So we have engineering, biology, chemistry, electronics. We'll name the specialty, it is there in tissue engineering. So what I will do is that the other question is, why did I come into tissue engineering? So this is because we have in urology one problem called urethral stricture. Let me just see if I start with that. Yeah. So now one of the things that because there are not many people, Indians are in tissue engineering, we will never find a mycology stories of our own in any of the tissue engineering journals. So I thought we will start with this and probably put those as the right articles. And you find about the story of Ganesha where the head was transplanted and people say, how it can be possible because nerve cannot regenerate. But that was proved to be wrong in 2006 when nerves were regenerated. So nerves can be regenerated, and that probably explains how it also can be transplanted. So what we didn't know, the technology, we said, okay, it's all nonsense. I think more relevant even today was this Vedavyasa, the story of the Kauravas. When the Pandavas and the Kauravas, the mothers were pregnant, the Dharmaraya was born first. And then the Gandhari, in frustration, she shrieked, and the amorphous mass of tissue came out, apparently the story says. And then Vedavyasa came in and said, okay, don't worry. And then made 100 pieces of that and kept in a pot. And then said, leave it here for a few months, then the children will be born. That's the story. We all said, what can be done? What if you can look back? I'll come back to this at the end of the talk. It could be he was the father of stem cell biology. He knew how to grow in the medium, which was self-sustaining and also had a evacuation and then all the waste products going in and regenerated. Probably he had a technology. And here now to make a tissue culture grow is so difficult doing one, I know. But this man could do it in parts and say very, very emphatically, at the end of this there will be a child born. I think that shows probably now he has some other thing on a different dimension which we don't know. So in the potential tissue engineering, what are they? So there are two things that we talked about, the stem cells and then the induced pluripotent stem cell. Stem cells or the stemness of the cell represent the ability to differentiate any level you want. So you have pluripotent means you can generate any organ of the any organ that it can be from the ectoderm, endoderm, or from the mesoderm. And the totipotent have capacity to multiply in one area, one layer. It can go to any organ in that layer. Then you have differentiated cells. These are the cells that have been used in the earlier part of the engineering where you had stem cells, and the fantasy was, oh, I got my stem cell, I can generate my bone, generate my cartilage, generate my heart. Whatever people thought and whatever early tests they did, they went to the press. That's how people develop sort of fascination about stem cells. Anything that forms stem cells, if there's a knee injury, put a stem cell. If there's a back injury, put a stem cell. If it's an heart attack, put a stem cell. And it works. What works? Nobody knew. What do stem cells do? Nobody knows even today. But a lot of papers are there talking about stem cells being able to go into any direction you want. Yes, it can go, but we have no control of it. That's important. So you can put to the liver and say, you go in a medium where the liver can regenerate out of those 100 cells, probably 80% cells can coax them to go to the liver. 20% you cannot. You have no control of it. So the reason I keep on saying this is that after being a surgeon and coming to cell biology, I find there's a tremendous order in the cells which I appreciate, which we don't know. But we talk as though we are gods, but this is not the reality. So I just want to keep on telling you about that. The induced pluripotent stem cells was coming because stem cells came up with a ethical problem. The stem cells came from the embryos. So once you take the cells from the embryos, the interstitial cell mass, then we could develop into different organ layers. But the problem came in that once you take over the cells, the embryo dies. So the question was, when did the life begin in the embryo? Nobody could answer. That question has been really bothering everybody. So embryonic stem cell research is really curtailed because of that one particular point. So if that is so, then can you get stem cells from somewhere else? That is, the cells which are all differentiated to one level, can you bring them back towards the stemness? Is it possible? That's how the induced pluripotent stem cell concept came. Two Japanese fellows, Yamanaka and Takashi, did it in 2006. They used factors, and then the terminal differential cells came back towards the pluripotent stem cells that now we can do from fat cells, skin cells, bone marrow cells, and all those things. So once you got that, can you come back and then develop all the organs like what we did before? Again, there's limitation in technology because we differentiated from the terminal differential cells back to the stemness, we don't know. And how long they retain the stemness, the extent of the stemness, when they go back, all those parameters are still unknown to us. So the principles of tissue engineering, which I want to show, there are basically three things. Sorry. So there are three aspects in tissue engineering. You take the cells from the patient and then grow them in layers. You can grow in monolayers or multi-layers on a scaffold, and then probably sometimes you put in biomolecules and then put it back to the patient once the graft is done. So there are three things: the cells, the scaffolds, and the biomolecules. These are three. So these are the three things that components form the part of the tissue engineering. So once you get the cells from any organ you want, there are differential cells, then expand them all. This is done in the tissue culture rooms, and the scaffolds or the biomaterials, this is where the mechanical engineers come in. Biomolecules are the different drugs which will stimulate the cells on the scaffolds to go towards a particular direction like cartilage, bone, or something like that. So this is actually the basis of any tissue engineering product. So in the scaffolds, we have a lot of work actually was done by engineers before even the cell biology took over. So they were using synthetic scaffolds or natural scaffold. Natural like collagen is one of the natural scaffold, or silk fiber is natural scaffold. But we have synthetic ones made of polygalactones, and different varieties of synthetic scaffolds have been available in the market and are all approved by the FDA also. Then you have the scaffolds can be based on the diameter of the pores on the membranes on which the cells grow. The macro, the actual virtual hardening pores in those membranes, and cells just try to get attached in one layer. Once you have micro scaffold, there are small holes in the scaffolds, and in those holes cells attach on the surface, and through the holes try to come below that. Once you have this nanoscaffold is like the base. So multiple layers together into one, and then cells will be static. Many of these layers will form on the nanoscaffold. I just want to show one picture, the one which you are using at this point in time. These are actually the nanoscaffolds. Because the Urological used it here, this is done by a technique called electrospinning. Electrospinning technique, again, how serendipity helps. The person who invented it was a man who was trying to understand this electrospinning for a long time, but he couldn't understand because the principle of this is that there is a tremendous gradient of voltage of 30,000 volts to zero. In between that, once you put the material, they get vaporized and then they form into fibers. So this is controlled with a needle and a force. Then he met the engineers who were dealing with the lighting, and those were dealing with millions of volts. So they helped him put the electrospinning machine. That's how the nanofibers were actually formed, the electrospinning machine. And we have a collaboration with the National University of Singapore where they make these nanofibers for us. Now, in urology, I come back to where we started. So this is the urinary bladder. This is the urinary bladder. That's the prostate and the passage. And then there's some things that get a narrowing to the passage. This part happens because of the inflammation, injury, or catheterization, something the narrow passage is narrow. So when this gap, the area gets damaged, now you've got epithelial cells, suddenly they get fibrous tissue. So if you cut it, new fibrous tissue will form. If you dilate the break, new fibrous tissue will form. So this has been a very big problem. And this is a very big problem in the lower socioeconomic strata, and we assume that there must be about 2 to 3 million people in this country who are in this problem. Because we deal with the lower socioeconomic strata in our free clinics, we thought that we have to solve this problem somehow. So the concept that we came up with that as long as the nature wants to heal, it keeps on healing the fibrous tissue. Because once the damage occurs, fibroblasts multiply faster than the epithelial cells. They come together and they come to narrowing. So suppose you take away the fibrous tissue and then allow it to grow faster. At the same time, grow an epithelial tissue and put it back in the same area, in tube form. Then you'll find that the nature doesn't have to heal anything, so that it stops. So that was a concept, and actually proved in our preclinical studies, and we did a clinical trial of 6 patients who were done very well in the last 3 years follow-up. I just want to show one picture where the opening is kept. Sorry. So this is the cystoscope picture of the patient where the blockage was there, and you're putting a graft, and in the 3 years follow-up is still maintaining the whole opening intact because the epithelial tissue prevented the fibrous tissue from growing. So we succeeded in that. Then the question was, how did we succeed, or where did we succeed? We didn't know, because there was not enough data anywhere in the world to understand this cell biology. So I started looking back and understanding. So studying cell biology, I think my wife will tell you that I spent hundreds and hundreds of lectures, online lectures, listening to lectures, reading, talking to scientists. Then finally decided that the best way to do that is to build our own lab, and we built the tissue culture lab of our own to understand. So I have now 5 scientists with me to work together with the help of ISC, NCBS, and scientific advisory board across the world, trying to understand the data, how the cells behave, and why they succeed. So I think I can talk about that in a different picture. So now what I'll do is that some of the situations, now can you apply the same principle to different organs? So for example, now you've got a kidney. the patient and grow the kidneys extremely difficult because there are 3 different layers. So grow them into, and once you look at this, you will probably appreciate the nature, how beautifully 1 million units are compressed, zipped into 1 kidney, 150 units, so beautifully, and the physiology goes on. You try to replicate, you find it so difficult. So what we have done, the de novo kidney from the embryos have been developed to the level of metanephros. Beyond that, we are not able to maintain them more than 18 days. That's where our research so far. But the 2 applications which we are trying to pursue with the help of nephrologists, there are 2 applications which are probably relevant even today. One is that we can grow the tubular cells of the kidney in a multi-layers and then over a membrane and use the blood for dialysis through the membrane of where the tubular cells of the patient is available. If you do that, you don't have to do the dialysis like what we do. We do over 3 times a week. You have to do probably once a month. A person called David Jones in Michigan has been pioneering this technique. We are in the process of liaising with them to see if we can get transfer this technology to us. The second application that is available in the kidney is that kidney also produces a hormone called erythropoietin, which is required for developing the red cells. And that is produced by a particular fibroblast. So we can develop this fibroblast in the lab from the patient's own cells and then inject back to the patient. The patient can generate his own erythropoietin as required. That will obviate the need for erythropoietin, which will cost thousands of rupees for every weekly injection. These are the 2 clinical applications which are relevant today, possible, probably possible. So we know in the next few years of time. So now they just come to organ the heart. So the fantasy about the heart is suppose there's a heart attack, inject the stem cells. Stem cells will go to the air, be damaged, and then form the wall on the heart. So they use the embryonic stem cells, adult cells, umbilical cord, blood cells, and all those things. In animal studies, they have shown that these cells can go and regenerate the cardiac muscle. Yes, they do that. But the only problem is that the arrhythmia, that is electrical, the heart contracts because there is an electrical activity in the muscle which precedes a mechanical contraction of the heart. But once these muscles are developed, for some reason they are unable to coordinate with the electrical activity the rest of the heart muscle. So arrhythmia is a problem which we have not been able to overcome yet. Once in the one which is really fascinating, which we have done. I just want to show this was done by the Massachusetts MIT people. The concept is very simple. Now we have got a baby inside the womb, and then by ultrasound they recognize that there is a valve problem in the child. So what you will take the umbilical cord cells or the amyloid cells, then make a scaffold, and then put those cells, and they form a valve. So the child has a valve done before the child is born. So after the child is born, you take out the scaffold, put the valve to the child. So with own cells, there will be no problem, no other rejection problem. That has been done experimentally. These are the valves which are generated in the lab, and you can put it back to the patient. So diabetes. Diabetes is the one that really people fascinated. Why should you do something in tissue engineering? It's very important. It's very, actually, I think, innovative ideas have come because islets of the pancreas or the beta cells are the ones which produce insulin. Suppose you take the insulin, the beta cells, and multiply millions and put it back to the patient. Then the patient should have insulin forever. Well, that's a very interesting concept. But actually, what has happened? We have used embryonic stem cells, insulin progenitor cells. They have been used in animals. But unfortunately, what has happened is they are all developed into small teratomas. Teratomas are uncontrollable benign tumors in the patient, in animals. So that's one thing to inhibit people from using embryonic stem cells. But the latest, about a year ago from Argentinian study just shown, is that you differentiate cell outside towards the islet cell in the lab and inject back to the patient. That they have shown that the beta cells can produce insulin for about 90 days. Beyond that, what happens? The cell senesce. See, it's a very, very amazing concept in the cell. Nothing remains forever. And the cells that are born, they have a program to die. This is called apoptosis. So once you develop a cell at a particular level, they already have a program to die called apoptosis. And recognizing this by what's called telomerase reaction, where the chromosomes gains become smaller. Telomerase reaction, you gas-based testing. Can we implement that? People are working on and say that they announce periodically or sporadically in the paper saying we have controlled aging, we have controlled this and that. I think one thing you have to remember that someone's scientific group keep on presenting in the newspaper is only for one reason, that they get funding if they present in papers, otherwise no funding afterwards. So I think that's one reason that directs them to do that. Anyway, that's apart from this scientific part. The liver part, liver is another area where we have a tremendous amount of need or unmet need in the clinical practice. You can imagine that mother gives a part of the liver to the child, and cirrhosis, liver necrosis, infection is very, very high in this country and in most of Southeast Asia because nutritional, viral, or toxins, all sort of things, we have a very high problem. So a liver has a tremendous ability to regenerate. Suppose you have some cells and develop them and then put it back to the patient. I think that would be ideal. But so the cells are being used, or the hepatocytes which are found outside, the embryonic stem cells, or the bone marrow cells which also can trans-differentiate to hepatic cells. These have been used, or use the biomolecules where the liver cells in the liver area stimulate them to grow. So this is another way of growing the liver cells. So these are all the things that have been done experimentally. So what is available in practice is called bioartificial liver. This concept is quite simple. Here the hepatocytes are grown from the pigs and their antigens are taken away, and on the membrane the patient undergoes a dialysis just like the kidney. Then the blood, which is containing a lot of the waste products, are dialyzed through this membrane of the pig hepatocytes, and the blood gets purified. There's a small bioreactor, so through which all this happens. And then what happens is once the waste products are not there, the liver, the native liver itself starts regenerating. And that's been shown in the phase 1 and phase 2 studies in Pittsburgh. I'm just mentioning this because we have been asked to take up this project by the end of this year. We may be surprised that we are not able to take the project because we don't have scientists to take it up. Then the knee joint and the orthopedic areas are the ones which fascinates us because you find that the bone and the cartilage, which is like a washer. So the washer is the one that gets worn off with age by friction. And what we do right now is the knee replacement. So replace the whole thing because we don't know what to do with this. Suppose, imagine a concept that you just take a bit of this cartilage or some other way, you grow this cartilage, then put it back to the patient, then you don't have to do the knee replacement. I think that sounds very logical. And what has happened, the two groups, one from Germany and one from Israel, have succeeded in doing that part right now. The German group, what they do is that to do the arthroscopy, take a bit of the cartilage, grow them in the lab in small spirules called converse spheres, and then through the arthroscope, they put it back to the patient, and then slowly the cartilage spreads over and then regenerates. And the Israelis have come up on the biomedical side. I was only talking about the nanofibers. I didn't want to confuse a little more. There's another thing what's called, once you have these nanofibers, and then you have depending on the pore size and density and the distances, what's called etching on the nanofibers, the cells when they start, they can be made to go towards the cartilage, bone, heart, whichever, depending on the architecture on the nanofibers. So the Israelis, what they have done is they have manipulated the architecture on these biomaterials so that when you put the biomaterial inside the knee joint, it forms artificial cartilage. So this has reached the phase 2 level, and this is one of the things my orthopedic colleagues are asking us to take it up. Then the interval disc is the back surgery. In the back, a lot of people come with the back surgery. What we do is remove that disc and say, okay, fine, you can't bend further, you can't do this, that, and that. Suppose you say that I'll give you an interval disc for you. I'll grow that and do it for you. Then you would say, okay, I'll take that better than this. Unfortunately, what has happened with both the knee and this, some orthopedic people have become a bit more aggressive and they put sensors. Take sensors from somewhere, put it and say it works. I think that's probably, to me, is very unsafe. We can probably skill the whole project completely. We don't know what product works, what the stem cells will do after going inside, what will they become, you don't know any of those things. So this way is efficiently in a better ways, looking, differentiate them to cartilage, differentiate this, and then put it back, you know exactly what you're putting, you have a quality control on the material development. This has been also been pursued, but we're not been successful because it's a very intricate area. You've got the bone, and then this is thicker cartilage, and this is like a bad butter inside. So these cells are grown from the notochordal cells which are present in the bone area and transdifferentiated to the nucleus pulposus, which is the one that extrudes out, and put it back, inject it back like silicone gel. So that will take care of your that problem. The trachea is the one that made a news about 7 years ago. What that is the patient is on the ventilator. What happens, the tube is going through that. Because the irritation, the whole area is narrow. But right now we don't have any method to do that. So what this Mashinani is a group of people from England did is they took a scaffold and the cells of the patient and grew the cells and made a tube and put it back to the patient. So trachea worked. Say patient owns cells, there's already a scaffold, it worked very well. Dolly the sheep was the one that really made news in 1986 when Helmet and Campbell, they from Rossall Institute in Scotland, produced the sheep. And people thought, oh, the concept is simple. So what we do is that take the mammary cell, the somatic cell from one sheep, and take the oocyte and take away the nucleus, and put the nucleus of the somatic cell into the gonadal cell, and then you develop, if the salivate mother, a new clone. So the somatics of the father will become the clone, or the sheep is produced. So it can produce lots of clones of the father. Of course, it produced a lot of interest in the United States, apparently, because a lot of the billionaires thought that they would not go to the hazard of getting married and have a child, you would probably have a child like this. And apparently supported a lot of clandestine researchers. I don't know what happened with that. But this did not succeed and go forward basically because the success rate of the technology is only less than 2%. But I would like to tell you at the same time, in our own Bhagavata, there's a similar incident. When Narayana Rishi was waiting for the penance, Indra, as usual, sent Rama and Menaka to disturb the penance. But Narayana Rishi had so much of control on himself. He said, you are bringing this deity to disturb me. I'll be more beautiful than what you have. And created Urvashi. Uru is from the thigh. He created her from the thigh and gave it. So now he cloned from his own somatic cells a lady and gave that to the divine people. So whether you can call it a story, but if you want to believe, they had a concept. So where are we going now from here? So I'll just close with a few things and give time for interaction on this. This is a 6-axial robot. So we are asked to participate in this from Cambridge. So what it does is, if you keep the cells here, at the end of 3 weeks, you get tissue at the end of it. How it works is that you prepare all the processes, and so everything is defined. Temperature, oxygen, fluids, washes, everything is defined. So there's a program logic for this robot. And once you put it into this machine, at the end of it, you will get the tissue you want. This is a project going on. Already this is available for skin in Stuttgart. So this we are looking at. Skin gun is a very, very fascinating project. I think people want to see the video. It's available on YouTube as skin gun. Here what you are seeing is that there's a tube with growth material and the skin cells. It's like this. Actually, it's a very big problem about energy, but we're not able to solve it yet. In case of burns, there's a superficial evaporation of the liquid electrolytes from the body. And then what the technique is done to take a skin from other area of the same patient. The skin is in 7 layers. So it's separated all those cells in the next 24 hours. You can grow them into at least 1 million cells. Then put in the growth material and spray them on the area of the burn. So they start growing on the skin, cover the skin and grow there and cover the whole burn area. This is not a latest technique. A lady called Fiona Jones, she used it in Australia for the polyvitreal, and she was given the Australian Women Award in 2007. But we are unable, though we have the technology, we are information I can, because cells are already there to use it. So that's where one can prevent it. The immunotherapy is a very fascinating therapy, which we are putting up a tumor tissue culture lab for this. What we know is that normally, when the cells are multiplying, there is a small error in the protein structure of a cell, and those cells multiply, they go over the control of the body for some reason, and they become the cancerous cells. But the cancerous cells are already always happening in everybody's body, but the normal body defense keeps on destroying them because it recognizes what is self and what is not self. Any little change in the genomics or the proteomics of these cells, it just recognizes and then kills it. But the multiplying cells overwhelm the body's defense and the cancer forms. So if that is the concept, then what you can do is that find these cancer cells which have abnormal protein, and then body defense cells which are recognized or sensitized to these abnormal proteins. Take the body cells, multiply millions. So improve your body defense. So millions of those cells from the patient, put it back to the same patient. These cells are called dendritic cells. This is part of immunotherapy protocols that have been followed, trying to be followed. But the success rate, we have not found those successful, though considered is very good. Basically because we don't know which gene is responsible for the abnormality. So till we really find out exact that particular locus, I think still some experiments have to go on this immunotherapy. The drug testing artificial skin or artificial organs is very simple. For example, in this country where they have a lab where the skin is not a new soap coming out, they test what the toxicity of these new chemicals. You can test on the artificial skin bank. These are the things that are going on. And artificial organs, similarly, you can grow the organs from the animals and keep them and do testing all the drug discovery, new drugs testing, pharmacology, pharmacokinetics can be done to these organs. And the drug production also, we can multiply the cells which can release the drugs through either E. coli or with the genetic manipulation of the cells. You can produce, also make them produce insulin. That's one thing that Biocon has spent most of the money recently. So making the E. coli to produce a lot of insulin. So where are we now? Because there are challenges. The ethical issues, because as I said, embryonic stem cells you cannot use because we don't know where the life begins. So that's where it stopped. And then we don't know exactly stem cells, what they are up to, how long they retain the stemness, and when they change, where do they go to. We are really, really ignorant. I think somebody asked me this about a week ago, we had come to our lab and said, oh, I think I've made a lot of straight, I think you must have said, what do you think you know? I said, well, it's like huge solid iron ball, which you don't damage also can never measure, and it's scratching the surface. Somewhere some dust particle we are seeing, and we are excited about it. Some shiny particle gets Nobel Prize, that's all. Beyond that, I think still we are very, very immature about the whole thing. The regulatory issues, it's a concern all over the world because of the quality control, safety parameters, efficacy parameters one puts in. And we saw more so in India because the Indian regulatory issues, Indian scientific studies are not recognized in the world because we don't follow proper scientific methodology. And that's one of the reasons we formed our lab to give credibility to scientific research. So I think somebody can visit us that the number of quality control parameters putting is much more than anybody has put ever before. But what we want is that when we come out, nobody should question that you can do this test, this is a good test. Other problem is regulatory issues that in Delhi the people occupy the positions because of their political connections rather than their scientific ability. And there are only two recognized entities, either a device or a drug. So actually I was in a meeting 18 months ago in Delhi and they asked me about tissue engineering. I was a champion for tissue engineering. They said, is it a device? I said, no. Then it must be a drug. I said, no, it's not a drug. If it's not a device, that drug will not exist. I mean, that is the way of thinking in Delhi regulatory issues, so what do you do? So we're in the process of pushing for another regulatory issue separately for biologicals, and hopefully that next couple of years we should have some regulatory issues sorted out. Doing clinical trials, again, requires a tremendous amount of caution and commitment from the scientists, clinicians, and the people involved, because out of immediate gain, sometimes you do a lot of shortcuts I think which has to be absolutely avoided, and then only the clinical trials will get recognition. And translation to commercialization is a very big problem in biologicals because the technology, whatever technology we talk about, is never 100%. So there are always anywhere from 2 to 5% minimum failure in the scaling of operations. So I can say that this works for this fellow, what are the alternatives? It doesn't work. So you should have alternative things. So if you start eating alternative things, it will be like what we do right now, that you have an electric current, generator, backup UPS, like that. So it keeps on having so many backups. So this is what's going to happen. So that's where the commercialization or the scaling of operation from a research to commercial operation is not happening. And also, second thing is that not many clinicians are getting into research. Unless the clinicians get into research, patient application will not happen. I mean, that's one of the main objectives that we started a lab. Already we have about 5 clinicians with us who are taking different branches in our clinical application. So just a photograph of the center that we built a year ago. This is in Sridhar Research Center at the Bangalore hospital. And the clean room. This is another thing, it's a learning process for me because they said you build a clean room. I said, what's our clean room? They said clean 10,000 plus 10,000. So, but who will do it? It really took me understanding the air exchanges, particle counts, and putting those filters. About 6 months of my time, understand what clean room technology was. So actually now we are writing a book on making a clean room. Just finish the draft. So here is the our laminar airflows, zero microscopes, emergent microscopes, our carbon incubator. These are the ones what we have are the HEPA filters. So the particles when coming from outside the air, the exchange is about 50 times an hour. So if I've got class 10,000, class 100, it will be much more. So the air goes through 20 micron filter, 8 micron filter, come to 0.3 micron filter. So all this is an engineering concept. So we have to learn. We took the help of electron people who are doing the semiconductors and the pharma people who are done the FDA approved lab. And so we learned, and I don't say we learned, but we did something. And this is our non-clean room area where we have meeting rooms, staff rooms,